Now we are going to carry on with the examination of the hand. Examination of the hand, as any other examination in the body, it will start by inspection, palpation, and movement. By inspection we have to look for each part of the hand. We have to look for the skin, for the nails, for the joints, and the muscle. This is done by inspection. By inspection of the skin, we have to look for any rashes, any erythema over joints indicating septic arthritis or gouty arthritis, rashes over the knuckles as in Gottron papules, or psoriatic rashes, psoriatic scaly papules of rashes, or dilated loops of veins in the nail folds, which are present in dermatomyositis, scleroderma, and systemic lupus erythematosus, nail fold infarcts, and vasculitis. We have to look for any palmar erythema. We have to look for any pallor in general, pallor in the palmar creases indicating anemia. Any scar of carpal tunnel release, tendon reinsertion, and if there any swelling of the joints, okay, and in general. But just in the skin, just about the rashes, about scars, about erythemas, and then we go to the nail and we look for nail pitting or onycholysis, which is characteristic of psoriatic arthritis. And then we go to the joints. After the skin and nails, we go to the joints. We look for any joint swelling. Joint swelling of the proximal interphalangeal joint will form a spindle-shaped finger. Joint swelling in the metacarpophalangeal joint will lead to loss of the indentation and the Hill Valley Hill indentations when the patient makes a fist. So all these can be inspected. From inspection, you can elicit all those signs. The other thing that we look for the joint, is there any erythema, as we just said, as in septic arthritis or gouty and pseudogout arthritis. And then we are going to look for any deformities, if there is hyperextension of the proximal interphalangeal joint and flexion of the distal interphalangeal joint, and this is swan neck deformity. Or if the reverse occurs, there is hyperflexion of the proximal interphalangeal joint with extension of the distal interphalangeal joint, and this is called boutonniere deformity. Or if there is hyperextension of the interphalangeal joint of the thumb and the flexion of the metacarpophalangeal joint, and this is called Z deformity. Or there is subluxation of the wrist joint, and there might be the dislocation and subluxation of the carpophalangeal joint, which may show to us as it was a swelling, but on palpation it will look like not a swelling. That's why a stepwise manner is very essential, by inspection, palpation, and then movement. In the inspection, we look for, as we just said, for deformities. Okay, we talked about the deformity, but the nomenclature, this deformity is called boutonniere deformity, and this is called swan neck deformity, and this is the Z deformity of the thumb. And there is also ulnar deviation of the fingers and ulnar deviation of the wrist. Now, by inspection, we are going to look for the muscle and tendons. We are going to look for the muscle bulk. Okay, is there any wasting of the muscles? Then we are going to start palpation. Palpation, usually we start with the patient checking the peripheral arteries, the radial artery. Then we start palpation as we just did in the inspection: skin, the nails, the joints, and the muscles. In the skin we are going to palpate first thing in general for the temperature of the skin. We are going to look for difference in temperature between different joint areas, between the interphalangeal and the metacarpophalangeal joints and the wrist joint and the elbow, and compare each joint aside. And we can do the same thing on the right hand. After that, we have to look for tenderness. Tenderness can be assessed just as you touch the patient or before you touch the patient. That's why on palpation you have to look for the face of the patient to look for any facial expressions. When you palpate the hand, you can squeeze it gently like this and watch for any facial expression, and also the interphalangeal joints. You can palpate for them and look for any signs of tenderness. Tenderness and hotness indicates active arthritis. Then in the palpation, we are going to palpate the skin in general of the patient. The skin, is it thin and atrophied? Okay, it might be normal as an old patient or a patient who is in chronic steroid use. Or it's thick and adherent as in scleroderma. Palpation, we can proceed with the palpation to palpate the rashes, to look for the scaly rashes of the psoriatic, for the guttrum papules of the dermatomyositis, for the nail changes of the psoriatic arthritis, okay, for the calcifications and the finger pulp of the scleroderma and the systemic lupus erythematosus. I'm not sure about the SLE, but in the scleroderma, the calcification in the pulp. We can look for also other things as the Heberden nodes in the distal interphalangeal joint and the Bouchard nodes in the proximal interphalangeal joint, which are osteophytes in the occurring in osteoarthritis. And we might look for crepitus in the joint by this way. So this is all done by palpation. So in palpation, we've done the palpation of the skin, of the nails, and we have the joints now. Now we have the joints. Palpation of the joints, we are going to start with the distal interphalangeal joint. With your index finger and your thumb, hold the finger like